All right, good morning, everybody. Happy New Year. Welcome back to GIM Grand Rounds. Nice to have you all with us. Today, we're going to be talking about the very challenging condition of lymphedema, how to evaluate it, how to manage it. We have two experts with us today. We have Dr. Franchesca Konig, who's an assistant professor in the Department of Physical Medicine and Rehabilitation. She's the medical director of Cancer Rehabilitation Medicine. She's also the medical director for the UC Health Comprehensive Network of Lymphatic Excellence. And we also have Vicki Ralph, who's an occupational therapist with expertise also in this condition, sees patients at the Central Park location, but also teaches courses on evaluation and management of this condition, both nationally and internationally. So very fortunate to have these two with us, and we're looking forward to learning from them. So thanks for joining us today.
Thanks so much for the introduction. Thank you for the invite. Happy 2024. I hope you all see and treat more lymphedema this year. That'll be the goal. So we titled this presentation The Eighth Vital Sign, because we obviously have our core vital signs, and we don't want to step on any other vital signs' toes like pain or BMI. So we're going to call ourselves the eighth vital sign in determining patients' overall body function. So we don't have any, no financial disclosures. Objectives for today are going to be to describe the lymphatic system and define lymphedema. We're going to understand the diagnosis and treatment of lymphedema, identify common misconceptions about lymphedema, and then review the importance of improving care coordination among interprofessional team members to overall improve the outcomes for patients with lymphedema.
All right, so we can say, well, what's the big deal? Why is it important to understand lymphedema? Feels a little funny here. Well, it's important because, first of all, I want to tell you a quick little story. On December 13th, I was able to meet a 13-year-old girl who lives up in the mountains in Salida, Colorado. 2 years ago, she's 13 years old. 2 years ago, she thought she sprained her ankle. She didn't remember spraining her ankle. Her foot and her ankle were swollen. The swelling persisted for 2 years. The parents took her 2 months ago down to Children's in Colorado Springs. This little girl endured testing from cardiology, renal, infectious disease, orthopedics for 2 days. After the end of these 2 days, the family was told, something's wrong, but we don't know what it is. We'll send you up to vascular at Anschutz. I met her in the vascular department here at Anschutz, and within a minute or two, I asked her to take off her shoe, and we'll talk about a diagnostic tool that we used just to pinch her toe. I saw that she had a positive stemmer sign, and from that was able to tell this family, you have primary lymphedema. So why is it important? Well, actually, there are 10 million Americans who have lymphatic, this is funny, huh? There are 10 million Americans who have lymphatic disorders in the United States. And that's more than all the people who have Alzheimer's. Should I switch? Yeah. It's a little bit annoying, isn't it?
There's a volume control.
Let me see if I put it in my pocket. Yes. Okay. Let's go like this. How about that? Does that sound better? Okay. So, but there are 10 million Americans in the United States. That's more than those who have MS, Parkinson's, MD, AIDS, and one more, AIDS and muscular dystrophy, all combined, ALS combined. So there are quite a few people who have lymphatic diseases, but yet it's kind of this anomaly that people just don't seem to understand. So that's what we're here for today. But what does UC Health have in common with all of these countries and all these cities and areas? Well, we are one of 12 comprehensive lymphatic networks in the world. And we got this designation 2 years ago after submitting an application where we reviewed from the whole system-wide. We are a network because this encompasses the entire state of Colorado. We looked at what are we doing in rehab, what are we doing in community outreach, what are we doing in genetics and research, plastic surgery, vascular. Combined, we looked at all of those things. We submitted application and we were able to get this distinguished designation as a comprehensive network of excellence.
So we're going to go into, again, defining the lymphatic system. And I don't know if things have changed much in medical school, but I didn't really get much training on the lymphatic system. It exists. I kind of understood maybe what it did, but kind of nebulous as well. And overall, I don't think things have changed much since then. But the lymphatic system is composed of lymphatic organs that include lymph nodes, tonsils, the thymus, spleen, and bone marrow. And these are all connected via a network of lymphatic vessels that run parallel to the venous circulation. And so in this diagram here, we have kind of how that lymphatic system works, right? In diagram A, we have a demonstration of the lymphatic drainage, returning tissue fluid to the bloodstream. And then in diagram B, we have the lymphatic capillaries that collect excess fluid from the interstitial space. And so the function of the lymphatic system are mainly three. So number one is drainage of excess interstitial fluid. And interstitial fluid refers to the portion of fluid that leaks from blood capillaries into the tissue spaces. And about 90% of this interstitial fluid is reabsorbed via the venous microcirculation and returns to the bloodstream. And the remainder, about 10% of the fluid, has a relatively high protein concentration and is then drained by the lymphatic capillaries. And so once this protein-rich interstitial fluid enters the lymphatic capillaries, it's referred to as lymph. Lymph is then transported via the collecting lymphatic vessels, filtered through lymph nodes, and ultimately re-enters the circulatory system near the point where the peripheral venous blood enters the right heart. And so the second function is fat absorption. And so essentially absorption of fat-soluble vitamins and fatty substances in the gut via the GI tract's lacteals within the villi, and then transports this material into the venous circulation. And then, in the end, again, immune surveillance. And so it defends the body against foreign particles and microorganisms. And so I'm sure all of you are familiar with Frank Starlin's principle, right? And essentially states that fluid movements between blood and tissues are determined by differences in hydrostatic and colloid osmotic pressures between plasma inside microvessels and fluid outside them. There was a revised model. Do you remember the year?
2010.
2010, the revised model. And essentially the difference between the classical and the revised model lies in the glycocalyx. And so this is a dense gel-like meshwork that surrounds the cell, constituting a physical barrier for any object to enter the cell. And in the revised model, in the post-capillary venule, the hydrostatic pressure has decreased, but the oncotic pressure still only opposes and doesn't necessarily reverse the movement of fluid. And the magnitude of this opposition is diminished by the influx of protein into the glycocalyx, and thus the net direction of fluid movement is out of the venules, and most of the interstitial water is returned to the venous circulation by the lymphatics. And that was a lot of words, right, to just describe that essentially the revised model is taking into account more of the lymphatic system as returning that fluid back in. And so lymphedema, essentially, right, we talked about how the lymph fluid is moved from the venous into the lymphatic system and so on and so forth. But in lymphedema, the flow of lymph through the lymphatic vessels is disrupted or blocked. And then this leads to increased interstitial pressure and an accumulation of that interstitial fluid, large proteins and cellular debris in the interstitial space, which then induces inflammation. The inflammation can cause further damage to the lymphatic vessels. Macrophages and lymphocytes release inflammatory markers, which then causes fibrosis, fat cell atrophy, and the classical sign of swelling. And so Vicky hinted at primary lymphedema. So lymphedema is essentially divided between primary and secondary. Primary lymphedema is lymphedema without necessarily an inciting factor. It's classified by age at onset. There can be a congenital or a hereditary component to this. And congenital lymphedema is defined by swelling that's present so there's three types, sorry. So the congenital is swelling that's present at birth or up to 2 years postnatally. This lymphedema precox is onset prior to age 35, so typically arising during puberty or at pregnancy. And then lymphedema tarda is onset after age of 35. Primary lymphedema typically involves lower extremities more, and there's an increased incidence in females. And then the current hypothesis, again, is that most cases of primary has a genetic origin, although a causative mutation is identified in only about like 1/3 of affected individuals. And then we have secondary lymphedema, and this occurs as a result of known damage or continuous strain to the lymphatic system. Overall, between both of them, secondary lymphedema is going to be much more common than primary. I think this is why that primary gets missed a lot. This is the type that I see being in cancer rehabilitation medicine. Outside, so in the US, the most common cause of secondary lymphedema is going to be either from cancer, right, spreading to the lymph nodes, or there's a blockage from that tumor, or lymph node dissection or radiation therapy damage from that. Outside of the US, the most common reason is going to be filariasis. Chronic venous insufficiency can come into play here as well for secondary lymphedema, any trauma, and then there's a link between obesity and lymphedema as well. So risk factors we talked about, right? This can be genetic, this can be hereditary. Hereditary conditions like Turner's, Klinefelter's, Noonan's, that can also increase your risk for lymphedema. We talked about genetic mutations, malignancy treatments, mainly again, a lymph node dissection. Lymph nodes are very radiosensitive as well. So in anybody who has received radiation, for example, a patient with breast cancer had a sentinel lymph node dissection, which is a lower risk procedure than axillary, but then got bombarded with radiation, that patient's going to be at risk for lymphedema as well. Older age has been shown to be a risk factor for lymphedema. And then obesity, there's been studies to show that extreme obesity can result in markedly impaired lymphatic function. And lymphedema, and then autoimmune diseases as well. There's this really great study from Sloan Kettering. They looked at 13,000 patients after an axillary lymph node dissection and saw that lymphedema development was significantly associated with autoimmune diseases, and that association was strongest for disorders involving the skin. And then to a lesser degree, this has been studied, but some suggest that risk factors also include other inflammatory disorders like arthritis and dermatitis and sarcoidosis. So your differential is going to be long, right? And especially, again, I think in my world in cancer, it's a little bit more black and white. You guys have a much more difficult task in diagnosing lymphedema. But right, we want to make sure that we're ruling out any systemic etiologies, congestive heart failure, kidney disease, obviously drug reactions, cirrhosis of the liver, all of this. I'm not going to go down this whole entire list, but of course, we want to make sure that we are ruling things out here before we diagnose them with lymphedema. So where can lymphedema happen? Essentially, the lymphatic system spreads our whole entire body. And does anybody know how many lymph nodes we have approximately in our body? Wild guess. No. Say that again. Close, 800. So 800 lymph nodes in the body. In the head and neck area alone, there's 300. In the gut, there's 200. So for example, like Vicky sees this all the time, like any kind of abdominal surgery and a patient comes in with lower extremity swelling, you know, obviously you want to make do your due diligence, rule out more systemic things, rule out a DVT, but keep that in the back of your mind as well, that can be lymphedema as well. So this is going to be a little bit graphic, but right, lymphedema again can occur anywhere if the lymphatic system spreads the whole entire body. And there's milder cases, there's severe cases. Vicky can attest, she's seen a little bit of everything. When we're thinking about diagnosis, this is where things get tough as well, right? We want to rule out other things. A diagnosis is mainly going to be clinical. On physical exam, you're going to see swelling, right? You're going to potentially, depending on the severity of it, you can see hyperkeratosis, where the skin becomes scaly and thickens. You can also see lymphangiomas, which are small blisters and bumps that develop on the skin. And then you can also have lymphuria, which is lymph fluid leaking from the skin. So this top left is obviously a very extreme case of lymphedema on the hands. Significant but milder case, but it can definitely vary. So imaging modalities, this is not our go-to necessarily, right? First off, we're going to do mainly a clinical diagnosis, but obviously, you want to rule out a DVT, of course, so a quick ultrasound is more than reasonable. Once you've ruled out other of those systemic causes, there are imaging modalities for lymphedema, but they're not used as routinely. So this lymphoscintigraphy is essentially like lymphatic system mapping. So what they do is they inject a water-soluble technium labeled large molecule, and they do that intradermally into the interdigital space. So when you're trying to look for like upper extremity, they'll put IVs in all of these spaces, and then that injects the fluid. It's painful. So this is not something that you're just going to be like, yeah, lymphoscintigraphy for everybody. No, it's quite painful, right? In the feet too, or in the hands. And then that fluid, or that molecule goes in and it maps out the system. So we have a little diagram here. This is essentially of the lower extremities. And so this patient had right lower extremity edema. The 5-minute image shows beginning of the ascent of the radio tracer from the injection sites. And then we have 45 and 90-minute images showing normal drainage of the left side, and then the right side obviously being affected. You don't see it. MRIs are used, but this is neither specific or sensitive. This essentially just evaluates for other causes of swelling, for example, a tumor, things like that. And then we have bioimpedance spectroscopy, which essentially is painless, cost-effective, so that's a nice alternative, right? But it determines the amount of extracellular fluid within an extremity by measuring the resistance of the body's tissue to the flow of electrical current. In the breast cancer world, we're using this more and more to identify early onset lymphedema, where we can really just nip it in the bud. But this is not something that we're using so routinely. Vicki, do you know how many we have? We have these here.
We have about 5 within our system. I know we have one up at Steamboat. We have one at Lone Tree.
Fort Collins, Colorado Springs,
and Cherry Creek.
Yeah, and the Springs down south as well. So this is a nice alternative as well. When we're thinking about staging, so there's several staging systems that are used to classify the severity of lymphedema. Using the International Society of Lymphology, this criteria here, lymphedema is staged based on examination of the affected area. I was going to say extremity, but I want to be mindful of that because it's not only the extremity, right, that can be affected. But this is, again, based on the evaluation of the affected area, and then looking at the volume difference between stage 0 to stage 3. So in the early stages, symptoms can be subtle, and there may be mild swelling with pitting edema because of increased volume of fluid in the interstitial space. In the subclinical or kind of stage 0, swelling may not even be evident despite impaired lymphatic drainage. So for example, again, I'm gonna go off the breast cancer world, but a patient with breast cancer comes to me and says, wow, my arm feels heavy, my jewelry feels a little bit more tight. You don't see any discrete swelling. I'm still gonna diagnose that as a stage 0. And Vicki, you were saying also that all of our patients who are
if they've had lymph nodes removed at all, we put them as a diagnosis of at risk for lymphedema, just to put it out there.
Yeah.
But even if it's just a sentinel node, it's still an at risk.
Mm-hmm. Please.
Stage 0 is at risk, or they're symptomatic?
They can be symptomatic, right? They can have that sensation of heaviness into the affected area. There can be some like dull aching pain. It's very non-specific. You're not going to see that swelling, but they're going to experience some symptoms. You may not be able to. Again, making it tricky.
You can pick it up with the bioimpedance.
Oh, sure.
The bioimpedance,
Yeah.
you pick it up.
But not on your clinical exam.
Yeah.
Or not necessarily. So then as the disease progresses over time, there's increased cellular proliferation, fibrosis, adipose deposition, and then that's associated with non-pitting edema, along with thickening and loss of the flexibility of the skin. In the late stages, then there's characteristic cutaneous changes that distinguish lymphedema from non-lymphatic forms of edema. And then Vicki was mentioning the Stemmer sign. This is the inability necessarily to tent the skin at the base of the digits. And they say that a positive Stemmer sign is a sensitive predictor for lymphedema in the extremities. But the absence of a positive sign doesn't necessarily rule out lymphedema.
All right, so how is lymphedema treated? We have two different phases. We have what we call an intense phase 1, where patients come in and they would receive, if they have severe swelling, they would have manual lymph drainage. We would do skin and nail care because these patients are at high risk for infection. We would do compression bandaging and teaching patients to be independent, doing exercise to help move the fluid out. Then once they progress, once the volume has reduced and we've gotten them into compression garments, then we go into a phase 2, which is more of a maintenance phase. And you can see that in this next slide too. Here we have the skin care, the manual lymph drainage. Manual lymph drainage is simply kind of a massage that works to move the fluid away from the affected quadrant to healthier areas. And then we put on these bandages. They look like ACE bandages. They're actually using what we call short stretch compression bandages that facilitate the muscle pump, and it helps move the fluid out effectively. So here we have a whole list of contraindications. Some of the biggies would be active infection and a malignant tumor that has not been treated yet, and also unstable CHF. Those would be our big areas. Precautions might be with renal failure, impaired arterial perfusion, malignant tumors, maybe a history of CHF where we just have to monitor, because sometimes with the compression bandaging, obviously that will put more pressure on the load, cardiac load, and could cause some issues. So we always take a look at that as well. So this is kind of cool. This is showing manual lymphatic drainage. The picture on the left that you see, this is without any manual lymph drainage, but injection, you'll see that dark spot there. That's where the injection of the ICG dye has been injected around the malleolus. But you can see not much fluid happening here. But when we take a look at the other one on the right, here's with manual lymph drainage, you can see the actual fluid moving on up the leg. This is a cool diagnostic tool. This was actually developed by a chemical engineer, and she looked at, I think it was during the Persian Gulf War, when people were crossing the bridges and they could see in the dark and all that. And she said, surely there's got to be something that how we could use that in medicine. And she created this form to be able to pick up the lymphatic movement. All right, so compression therapy. You cannot, if a patient just has lymphedema or has some swelling, you can't simply say, let's get some compression on you and you're good to go. Because the problem is the swelling will develop and build up at that top of wherever the garment is. As you can see, especially here in the arm, you can see that the fluid is managed below there, but it just kind of bubbles up there. So it's important that we teach our patients how to do self-manual lymph drainage or get them fitted for a good compression pump that can help and move the fluid away from that affected quadrant. You can see the bubbling up here, the bandages there, and then on the groin, the importance of getting that fluid up and out of there. If you don't, that fluid becomes hard and fibrotic. Also, there's a difference in garments. The one on the left is called circular knit. This is something that you could buy on Amazon. This is something you could buy at Walgreens. It's the one on the left, you can see, is something that I describe to patients will stretch north, south, east, west. You wear it, you will still possibly swell during the day, but it might contain some of the swelling. It's better for a vascular condition. The one on the right, I'm happy to say, as of yesterday, after a 10-year fight in Congress, Congress has approved to have Medicare cover these flat knit garments for Medicare patients as of yesterday. So it was a big fight, but these are custom-made garments. They're made in Germany, and they are measured to fit patients. So it's a huge win for the lymphatic community. Here are some problems with circular knit. So many times I've had, these are patients who I've had who, were fitted for, told to go get compression garments, and this is what happens. So CDT, complete decongestive therapy, really works. Take a look at these pictures here. We have before and after. And all of these are about 4 weeks after intense therapy. Before and after. And so you can just imagine the outcome with these patients. This gentleman is not my patient. He was in New York City. He worked at a hotel. He wore one of those long coats that covered his leg. He was actually slated to have an amputation. The surgeon said, what can we do? But after 4 months of surgery, of intense CDT, he got this outcome. And then 1 year later got this outcome. And by wearing these custom flat knit garments day, and then there's certain garments that you can get at night, this patient's been able to manage that swelling. So it's pretty remarkable.
And so complete decongestive therapy with a trained and certified lymphedema therapist is the standard of care of treatment of lymphedema. Again, folks don't have to be in lymphedema therapy forever. They're going to be in lymphedema therapy, reduce the size of the affected area, and then they're going to have a home exercise program, right, that they're going to do. Go ahead.
Should we be ordering them? Should we, or you don't need to be so far down the line? You worry about ordering them?
All of our lymphedema therapists are trained to measure and fit these patients. So you could order for PT, OT, lymphedema therapy, compression garment. And we would order for one of those flat knit garments.
Where in that therapy do we specify? Do we just refer to physical therapy and specify?
Well, it's good question. Interestingly enough, in the area of lymphedema therapy, OTs and PTs will do the exact same thing. And how our system works at the moment, we are working to try to clean this up. But unfortunately, right now, how it works is if you want to get your patient seen, we'd suggest an OT and PT referral, and one of the disciplines will pick that patient up. And if a patient is imperative that needs to be seen immediately, if you put the referral in and put an ASAP behind it, that will bump the patient up as well.
So there's two different referrals, right? For I kind of look at it for folks who don't have cancer and folks who have cancer. For folks who don't have cancer, you're going to put in regular PT and OT referral, and then in the common section, write lymphedema. For patients with cancer and a history of cancer, there is a specific rehab oncology referral. It's referral 2228, and then there's check boxes of what cancer type they have, and there's a checkbox for lymphedema. Like Vicki was saying, how the system works right now, it's preferable to put in both a PT and an OT referral because it can't be interchangeable, and then that expedites their care. And like Vicki was saying a little bit earlier as well, we have 58 total lymphedema therapists throughout the UC Health system, spanning from northern metro to southern regions. So it's nice to have this expertise, and I think from all the places that I've ever worked, this is the biggest network for sure. So in some cases, complete decongestive therapy is not going to work, or symptoms are refractory, and if it becomes a functional or a quality of life issue, then we can consider referring to plastic surgery. And there's different types of procedures that they'll do. They can do a vascularized lymph node transfer, where they are taking a lymph node from a quote unquote healthy area and then transplanting it to the affected area. They can also do a lymphovenous bypass, where essentially they're using the venous system to bypass that blockage. For these types of procedures, they are going to do that lymphoscintigraphy, and they are going to order it. You don't have to order it ahead of time. They will take care of all of that. And then liposuction has been used as well. Essentially, the thought process behind it is that once the lymphatic fluid spills into the surrounding tissues, it can cause inflammation and stimulate fat stem cells to grow. So sometimes liposuction will be used. To be honest, I have not seen it as frequently. If anything, I'm seeing the lymphovenous bypass more as a surgical intervention for this, and also they're starting to do this prophylactically in patients with breast cancer undergoing mastectomies or lumpectomies as well. So some common misconceptions. Number one, edema doesn't mean lymphedema necessarily. right? So edema essentially is a symptom, right? Lymphedema is a disease. In edema, fluid accumulates in the extracellular space. Lymphedema, we already talked about this high protein fluid accumulating and triggering a secondary tissue proliferation. It's thought that in edema, once you treat the underlying disease, we expect the swelling to get better. Lymphedema is chronic. What we know of it right now is that it's not reversible, right? Once you have lymphedema, you have lymphedema. And then this is also associated with an increased risk of cellulitis, which we'll talk about. And so if a patient comes in with lower extremity swelling, again, they might have edema and we could treat with diuretics if they have right CHF or something like that. But if they have lymphedema, you've done your due diligence, they don't have CHF, they don't have any other systemic issues, it's lymphedema, don't necessarily treat with diuretics. It's not appropriate for lymphedema. Misconception number 2, lipedema does not mean lymphedema. So lipedema is a hereditary condition. It's considered either X-linked or autosomal dominant. And in patients with lipedema, their BMI is going to be elevated, but there's differentiating points like diet and exercise favors obesity, whereas a disproportionate fat distribution between above and below the trunk is going to be the classical sign of this. There's also going to be some tissue tenderness and easy bruising, and this all favors lipedema. Lipedema affects the lower more than upper extremities, and essentially it spares the hands and feet. So we see in this stage 4, right, this patient's legs are rather large, but then the feet are kind of small comparatively. So this is going to differentiate, again, lipedema from lymphedema. And although the diagnosis of lipedema does not exclude the presence of obesity and lymphedema, it's essential to have that correct diagnosis to manage the symptoms in the early stages of the disease. And Vicki, do you see patients with lipedema coming in all the time, right?
I do see lipedema patients, but these patients you might quickly just get, there might be a component of lymphatic swelling, but if that comes down, you're not going to see the big wow factor that we had with the other patients with these kinds of patients, but the typical thing is to get them fitted with the custom compression garments as soon as possible. That helps relieve some of the tenderness that they have. Also, interestingly enough, with this group, it's a connective tissue disorder of sorts, so most of these patients can easily put their hands flat on the ground, no problem. There's a hypermobility component.
Yeah. And then misconception number 3, lymphedema does not increase your risk of cellulitis. The number 1 risk factor for an exacerbation of lymphedema is going to be cellulitis. So we always want to keep this on our radar. We educate our patients with lymphedema all the time to perform skin hygiene, take a look at your skin, make sure that there's no redness, no signs of cellulitis. And if there is, obviously we nip it in the bud really quick with a short course of antibiotics as appropriate. But this is something that we're working on, because what we see, right, is patients coming into the emergency room with cellulitis, and then they come back with cellulitis, and then they come back. So frequent flyers for cellulitis, and that needs to trigger, hey, is this a component of lymphedema if there's cellulitis in an extremity, right? So it's high on the radar of patients with lymphedema always. And again, we kind of nip it in the bud with some antibiotics.
There's some literature to say that we overdiagnose cellulitis.
Fair. I don't necessarily, Vicki.
Well,
oh, that there's a thought that we may be overdiagnosing cellulitis if folks coming in with increased redness, and it's not necessarily an infection.
Right, but oftentimes if it's a lymphatic limb, just the presence of that high protein rich fluid in that tissue, it might look speckled and all, but that high protein, I often will describe to patients as if they're carrying around a petri dish in their leg, and all they need is a scratch, a mosquito bite, a hangnail to ignite an infection, and it can come upon quite quickly. Oftentimes with lower extremities, the swelling might happen from a lymph cyst that's happening in the scrotum or the labia. It's not seen, and it's a place for infection or bacteria to enter the system.
All right, and so we have a few case studies for you all today.
Okay, so here we have a patient clearly with some CVI. See this swelling, this hemosiderin staining. The patient is 50 years old with a long history of bilateral lower extremity edema. He reports that for the past several years, the swelling would worsen during the day, but reduce at night. But currently it's persisting day and night. He's been fit with over-the-counter compression stockings for 2 years, but he stopped wearing them because it started causing creases at the ankles and it hurt. So he has a BMI of 42. Edema is present in both legs. There's pitting noted in the feet. Distally, the legs are fibrotic with minimal pitting. Mild soft edema is present at the knees and the proximal legs. As I said, there's hemosiderin staining. Venous studies have ruled out a DVT. What's the most likely cause of edema? Is a plebo-lymphedema. So oftentimes with CVI, you'll get this component of both. When someone has CVI, you'll have this component of a dual diagnosis of the CVI as along with the lymphatic impairment. And of course, I always ask the patients, and it's one of the goals for therapy, where are you sleeping? So many times they're sleeping in a recliner where their legs are always hanging down. So we try to see if possible to get them into maybe even a hospital bed or some kind of a goal to kind of strive for getting those legs elevated better.
I have a question about that. I feel like that case is what I see.
Exactly, me too.
In chronic venous insufficiency involving
Yeah.
So what's the first one or two things you need to do? Try some compression and let me know how you do. Let me try to get you some custom fit compression and see how you do. Is it to make a referral or let me clinic and you all tackle it? Trying to think what are the most important things for out of the gate? Make sure you don't have to be
Okay, so if we go back to here, if you pinch the toe, so you cannot tense, you cannot lift the skin on that second digit, it's evident this patient has lymphedema. So that's, and that's
So it's going to be like right here. Yeah, not the digit per se, but that interdigital space.
Right in here, if you can pick up that skin. And if it feels like here, you're pinching a little hot dog, that's lymphatic, that is called a positive stemmer sign. So if someone has a positive stemmer sign, send them to a lymphedema therapy. But this is probably the most common presentation that you might see of lymphedema.
I think in the same vein also, depending on the severity of it, right? Because if a patient comes in with pretty significant lower extremity edema, you've ruled out everything else, you're going to, recommend compression stockings, they're going to go on Amazon and buy whatever, and then they're going to say, it didn't work. What should we do? So in those cases, I think when it's a little bit more advanced, and obviously what you see, but also what you're asking the patient, mobility is affected, right? They're unable to pick things up from the ground, those types of things. Then I would just say refer directly to lymphedema therapy, and they can get those custom compression garments. It's really great to have them plugged in with lymphedema therapists as well, because they're able to order all of these things and you just have to sign off, right? And obviously compression stockings and compression garments are going to wear off over time. They're going to need new ones. It's going to lose that elasticity, and then they're already plugged in with lymphedema therapy and they can just get that done quickly again. So the plastic surgeons are going to do these types of procedures: the lymph node transplant, the lymphovenous bypass. Vascular surgery, right, is going to rule out any other vascular etiology for this. But for lymphedema per se, they don't have procedures that they do specifically for lymphedema. Yeah, if that's a component of their lymphedema, right, and if there's a risk factor, they have morbid obesity, it would be more than reasonable.
More to have the bariatric surgery. And also, if somebody has if they're morbidly obese, they wouldn't be appropriate for plastic surgery. Mm-hmm. Typically, plastics will say you've got to have a lower BMI to have their surgeries work.
Right.
I love it.
So I'm trying to think about how to parse. So the patient says, when I wake up in the morning, my legs aren't skinny. I should think more about lymphedema.
Right.
Venous insufficiency.
Absolutely.
And the person who says, I've applied compression. I'm not better. I should think lymphedema.
Absolutely.
Yeah.
The two go hand in hand, especially with this, the revised Starling's equilibrium that Franchesca was talking about, is that the more of an uptake is taken by the lymphatic system. So those two do go together more so than we might have ever thought.
And it's interesting, I think it's in England, they're not calling it edema, lymphedema, they're calling it chronic edema, because eventually the lymphatics are going to be involved, right, with the chronicity and the severity of it.
I've even seen it with chronic orthopedic conditions. Let's say someone's had a total knee and the swelling has persisted for 3 months. Immediately think of lymphatic therapy. The sooner you can get that edema out of there, the better the outcome, the less the risk of the chronicity of this condition, of it developing into lymphedema. Stephanie, come up here so you can, so the group at home can hear you too.
Should not have raised my hand. Something else to think about when trying to differentiate between chronic venous insufficiency or lymphedema. Don't shy away from referring to vascular surgery. We're always happy to see them. Often these conditions are going on concurrently. And so we can treat venous insufficiency, we can treat whatever's going on from a vascular perspective. And then if we have persistent symptoms, then get them over to lymphedema, because of that condition of phlebolymphodema, they can go hand in hand. Another thought, you guys can always order a venous insufficiency study. If you do have a suspicion for chronic venous insufficiency, excuse me, go ahead and order an insufficiency study. And if there's anything positive, sure, send them on over to us. We're happy to see them. And if not, then makes it pretty clear that you can get them over to lymphedema. So, no, not necessarily. So the venous studies that we have, it's nice to have them done through the vascular lab, not just through radiology. Those will often just be a DVT study, but actually you type in venous insufficiency study, you can do bilateral or unilateral legs if symptoms are unilateral, but an actual venous insufficiency study done by our vascular lab will be the one that'll be more helpful. Typically with palpable pedal pulses, that's adequate. And then you can be confident they'll be okay in compression. In the absence of distal pulses, yeah, just some ABIs would be fine. Just to make sure that you're ruling out PAD before putting them in some intense compression.
Mm-hmm. All right, well, let's take a look at this next case. Here's a patient who was referred for lymphedema for compression therapy. We can take a look. What do you see? The physician diagnosed with chronic venous hypertension with lower extremity edema. But let's take a look at what happened. 61-year-old patient with history of liver cancer, bilateral lower extremity neuropathy, an umbilical hernia, right femur fracture with total hip replacement repair. He's had a 2-month history, 2-month history of bilateral lower extremity edema. Many of the patients with lymphedema, it's a slow, gradual onset. It's something that might develop over a year, 2 years. I mean, it can be gradual. When you see somebody who has a quick onset, that might set up some red flags. He was recently discharged from the hospital where he was treated for severe bilateral lower extremity edema and ascites. Chief complaint is leg pain associated with swelling, but he's not been able to find compression garments to fit. So let's take a look. So he's appeared jaundiced. He has this soft pitting edema. You can just see there's just something different here. This is not a true lymphatic issue. Good protective sensation in the feet. But when we go to the next slide here, this is where you can really see it. The albumin level is low. When the albumin level is low, oftentimes what happens is that's because there's more of a protein developing in the interstitium, and that protein is higher than what's in the blood, and it causes this mass exodus. And that's where you see patients reporting this quick onset. Perhaps they may say, I've gained 20 pounds in this last month and I haven't changed my diet. I don't know what's happening. So all of these lab values are critical at looking at lymphatic issues. And when we go on to the next, we can see these red flags, the bilateral symmetrical edema. Lymphedema is often considered asymmetrical swelling. Now with CBI, yes, you'll have swelling both legs, but if you look at both legs, one leg might be bigger and they will not be completely they would be asymmetrical, not symmetrical. Here's someone with shortness of breath, that sudden weight gain, the high BMI, diabetes, hypertension, and then all those abnormal lab values. So what's the most common cause? Well, there's advanced liver cancer. And so in this case, lymphedema therapy is not going to be your first choice. Obviously, if someone has a hard time with ambulating and is just in so much pain, yes, therapy could help in a palliative sense, but you're not going to get that outcome that we had seen with perhaps you would with the CBI patients or your straight up cancer patients with the lymph node removal.
And another thought in regards to the timeline of lymphedema in the cancer world, at least, radiation is the gift that keeps on giving. It continues to exert its force long-term, months, years, decades. And so you can have onset of lymphedema or onset of issues from radiation fibrosis years after their diagnosis and treatment of lymphedema as well. So in the cancer world, keep that in mind as well.
I love that. Can I just tag on one thought? It's so interesting from a therapist point of view. When we see breast cancer patients, they're very versed in the idea of, I've had 5 lymph nodes taken out and 2 are positive. Anytime we ask a patient who's got swelling in their feet, have you had abdominal surgery? Yes. Have you had any lymph nodes taken out? It's a deer in headlights. You don't see them with any information about any lymph node removal. And it's always important to you can always go back in that tree as well. Take a look at, okay, you've got swelling in your foot. What kind of abdominal surgeries have you had? I've even had patients who've had hysterectomies, C-sections, any kind of abdominal cancer possibly will result in swelling in the bilateral lower extremities or one leg, one side or the other.
And there's no studies to show exactly how many lymph nodes removed put you at risk for lymphedema, but just thinking about it, like the more lymph nodes removed, the higher the risk. But it's interesting going back to those patients with breast cancer, they will tell you 26, exactly. Right? Or like the exact number, and other cancers won't be able to.
Okay, so this is a patient who, we'll say a 35-year-old, history of a melanoma in her right leg. Along with that, history of inguinal node dissection, low BMI, no complaints of pain, gradual onset of swelling in the right foot and ankle, and then up into the leg. So, with this patient was actually referred to Stephanie, who's here with us today, and to rule out a DVT. But in essence, in reality, this patient really wouldn't need to have that testing because it's a clear-cut case, because there was no pain, there's no discoloration in the limb, but rather it was just a straight up lymphedema, history of inguinal lymph node dissection, true lymphedema. But we've discussed it, and with the cancer history, you could see on your end perhaps referring for a DVT.
I like
But-
my slogan is in the cancer world, be confident, but be paranoid. So I would have gotten the ultrasound, but Stephanie, thinks this is right. Like she sees much more of cases like this. So more confident.
There was about a year and a half of red light scan, onset about 2 months and a year after the surgery. So they were asking for a question, do you see a much more chronic deficiency? Really was not. This seems to be a very simple
Yeah.
scenario of leg swelling, vascular surgery, I think chronic deficiency with people deficiency study, it was negative, got that off the table.
So in the end, right, I think you guys have gotten the theme that it takes more than one specialty to help patients with lymphedema. So lymphedema is common. We know this. You guys have learned today that the diagnosis and the treatment can be complex. Most of these patients are presenting to you guys, right, first. So it's important to identify this or at least know those risk factors for it. And in the end, right, again, going back to in med school, they don't really teach us so much about the lymphatic system and lymphedema. So who really treats this, right? It looks different across the nation, and folks specializing in this. There's, multidisciplinary clinics throughout the US, and there's different folks heading these up. The one in Boston is headed up by a plastic surgeon, right? In California, there's one who's headed up by cardiology, right? So it's just someone with an interest in this. But in the end, that interdisciplinary teamwork is crucial, right? And so we are working on creating a multidisciplinary clinic here at the UCH system. And so we are going to have vascular surgery, myself, lymphedema therapy, and plastics as well. So it's kind of like a one-stop shop for these patients. And again, we know that lymphedema is a chronic condition. Patients are going to live with this for the rest of their lives, right? And so our goal is for our patients to be as independent as possible in their function, their quality of life, and obviously in their management of lymphedema.
Mhm.
Go ahead.
The whole complete decongestive, the massage, get the fluid out of there. The sooner, research will show, the sooner that we can attract the swelling, the better the prognosis for that patient is. The swelling won't advance to stage 2. We can keep that limited at that stage 1 level.
And is she going to require she has to come back once a month?
No, she would probably go through an intense phase of therapy for 3 to 4 weeks, get that swelling down so that she was within perhaps 5 to 10% of her other leg, and then be fitted with compression garments that then would just need to be updated every 6 months.
Initial therapy and
Yeah, but also with them teaching self-manual lymph drainage and everything too.
But you mentioned that patient had a case study. But the lymphatics drain the venous part.
Yeah.
There's another question from the chat here. It says, are there any thoughts on chronic renal syndrome?
I've had several patients, they respond well to the manual lymph drainage and compression with CRPS. And I've been able to have people who've gone for therapy, they've gone to physical therapy for treating this for on and on and on, and seen the patient. If you get that swelling out, if you do the manual lymph drainage, you can fit them with the compression, they do well. So they will respond. But so that swelling, that discoloration that might happen in the foot or hand or so will respond to this therapy. Yes.
This is very helpful. I'm an addiction doctor, so a lot of folks I see have like unilateral like long-term rejection and a lot of these scarring. I'm curious, two things. So one is I feel like a lot of my patients would have difficulty coming to sort of like use for appointments for manual infection. Is there any sort of online like videos that teach patients and providers how to do this? And then the second question is if they can't do that, is there any harm to just doing like the compression, fitting them for some compression thing without first getting the manual lymphatic drainage?
I would suggest if you could at least get them involved. The therapist can work with the patient. And clearly if there's a patient, I have patients who are unhoused and living in their cars and that kind of thing. And we will work with the patients whatever we can. I have some videos that I've made that are out there that I can refer patients to do self-manual lymph drainage. And I always show patients, these access to these websites and how to do that. But I would say getting them into the right compression is important, as you saw in those earlier pictures where sometimes the inappropriate compression can cause actual more damage or deformity within a limb.
So another thought too, and this might, for your patient population, might be a little bit more difficult as well, but once folks go through lymphedema therapy, right, they've had their course, they're good with their home program, they're also sometimes set up with a compression pump, which is something that they're going to incorporate into their home program. Again, it might be a little bit difficult with your patient population, but it's a good tool and it's been a game changer for the maintenance of lymphedema. And essentially it's just, right, like the affected extremity, a sleeve, and it's a pump and it just does these like oscillating movements that mimic that manual lymphatic drainage. But the first part of your question was, is there more information for providers? And so closed training.
So I, outside of UC Health, I'm also an instructor for closed training and I teach lymphedema certification courses around the country and the world. And because of this association, they've offered all UC Health providers. If you are interested, you just take a picture of this picture. You just call Lisa, who's the operations officer there, and she can set you up for this 10.5-hour self-paced online course that you can take to learn more about the lymphatics. And it's hosted by Dr. Kathy Francis, who's a specialist in lymphatic disease. So overall, it's a wonderful course. So
we have been trying to get CME for this, but unfortunately, as of yet, we don't. But again, free, self-paced, it's a great tool. And closed training is one of like all the
premier,
biggest,
lymphatic education courses around the world.
And they're housed here in Denver or in Colorado.
In Colorado,
right. Yeah. So with that, we finish. Thank you all.